Hello, everyone. Thank you for joining us for our webinar on Step 4 of the International Mother-Baby Childbirth Initiative. I'm Ray Davies, and I'm the Administrative Director of this fabulous organization. And I am honored to introduce Deborah Pascali-Bonero and Julie Bonapace to lead our discussion on Step 4.
Well, thanks so much, Ray and Julie. It's such a joy to be here with both of you. And as Ray said, we both work with the International Mother-Baby Childbirth Organization. I have the honor of being the chair, and putting together these 10 steps has been quite a journey. We hope you're joining us with our webinars that are on our website, IMBCI.org, to see the other ones. But step 4 is one that's really passionate to me in my heart, something that I work with a lot as a doula, as caregivers at birth, is how do we look at pain or comfort, as I like to say, in childbirth. And Julie, you are such an expert in this, and we're so honored to have you here to guide us in step 4. Can you share a little bit about yourself and the work that you're doing right now around the world?
Absolutely. I think that you're mentioning that the whole pain management thing is really something big. It's big because we've convinced women that childbirth is painful, and we've convinced them to expect it, and to fear it, and to remove it. And the journey that I'm on really is to re-empower parents for birth, to tell them, to teach them what resources we have in our bodies that will help us work with these sensations. We've been doing it for thousands of years, and we've done it successfully. So obviously there's something in our body that's working, but there's also something that's inhibiting the activation of all these resources. And so my mission really is to re-empower parents so that they can discover the resources they have in their bodies, and that they can learn how to work together as a family to help this transition to parenthood. So that's really what I'm doing. And I'm training healthcare providers all over the world on these mechanisms because this is knowledge that has been lost. So we work both from the scientific point of view on the scientific evidence that we have to support the comfort measures that we have, but we also work with the intuition and with the wisdom that women and people have been carrying for thousands of years. So it's putting all of that together so that we can really support parents during their transition to parenthood.
Fantastic. Well, we're going to stop our videos for a second and screen share with all of you so that we can put up our presentation, and that will guide all of you that are with us through our step 4. And so you can see kind of our names up here, but I really want to get you to our website if you haven't been there, IMBCI.org, where you can see this and other webinars. And these are some of our key words around the IMBCI. I like to say we're providing respectful, quality care with compassion and love. So these are mother-baby steps. And Julie, tell us what we're going to cover.
Well, we're going to talk a little bit about the IMBCI Step 4 and the connection with the Society of Obstetricians and Gynecologists of Canada as the guideline that we've just recently put together, that's based on scientific evidence, and that will guide pain management for all of Canadian healthcare providers. So midwives, doctors, nurses, and anyone who's interfacing with women during childbirth. So we're going to talk about the link between the SOGC guideline and the Step 4. We'll talk about also the difference between pain and suffering, and how the hormones and the neurophysiological mechanisms are really the hardwired resources that we have in our bodies to help us cope with the sensations that we'll be experiencing in childbirth.
And our step 4, and this is kind of the short version, is provide drug-free comfort and pain relief methods during labor. I Love this image of the power of water. We'll be talking more on how this works. And our long version, each step has a shorter and a longer version. So the full step 4 reads to provide blood-free comfort and pain relief methods during labor, explain their benefits for facilitating normal birth, and avoid unnecessary harm. Show women and their companions how to use these methods, including touch, holding, massage, laboring in water, and coping relaxation techniques. Respect women's preferences and choices. And this is just so important for us, is that element, and you can see kind of the highlights, is to really explain, show, and respect. So often we find that things are put out there but not fully explained or demonstrated. And I feel often around the world, we're not always listening to what women prefer. So the IMBCI is really framed around that respectful care.
So now if we look into the SOGC guideline on pain management, I just wanted to cover the 9 recommendations that we have for Canadian healthcare providers. And we're talking about the same points that are identified in the IMBCI steps. So step number 1, the recommendation number 1 is that we want all healthcare providers to learn how to support physiology through hormones and neurophysiology. So what we're saying is that this knowledge is lacking in the trainings, in the initial trainings of healthcare providers. So we know that a lot of it is included in the doula programs, but in the medical programs per se, in many different countries, this is lacking. So recommendation number 1 is that this needs to be integrated into the basic training and also into the continued medical education that healthcare providers have. The second recommendation is that non-pharmacological methods, they need to come first. So that means that all healthcare facilities need to have non-pharmacological methods. And as a plan B, as a second step, if non-pharmacological pain relief has been used throughout labor and that there's still a need, then we can go into pharmacology. We need to do this because pharmacology presents too many side effects. And if we just use that as a first line method, we're going to have a lot of complications with our births. So we're saying recommendation 2, this is a 1A type evidence, which means it's a very high quality evidence that supports that non-pharma comes first before pharmacology. The second recommendation is that we need to prevent suffering. And today we're going to discuss the difference between pain and suffering. And this is done mostly through supporting women. The fourth step is work with and listen to women's needs. So that's also part of the IMBCI, which is respectful and respect and asking women what they want. So work with and listen to what women want. This will also create better satisfaction in birth. Recommendation number 5 is to reduce medical interventions by offering continuous support to women, combined to at least one other neurophysiological mechanism. So what we've noticed in our meta-analysis and in the work that we've done in research is that the best way to reduce medical interventions is through support. But when you combine support plus one other mechanism, one neurophysiological mechanism, you're going to increase the effects. So what we're saying here is to be able to increase the effects in reducing medical interventions, we combine support plus another mechanism. Recommendation number 6, support the physiology of birth by trusting women. So what we're saying is, this guideline actually even has physiology in the title, meaning that what we're thriving for is not just normal birth, because normal birth can entail many medical interventions. What we're saying is we're targeting physiology in birth, and we can do this by trusting that women have the capacities, the competencies, and the resources to have safe and happy births. Recommendation number 7 is that we need to enhance the production of hormones. And we will do this by reducing women's stress, by encouraging them, by being positive, by creating a calm, stress-free environment. So we're actually recognizing that the environment will impact the release of hormones. So we need to create favorable environments for women to be able to produce the hormones. Number 8 is to provide continuous support for all women. We have more than a lot of high quality evidence that supports this. And number 9, encourage parents to prepare for birth by learning about birth physiology and gaining skills to work with pain. So this has everything to do with childbirth preparation or prenatal classes. And we know that we have a lot of conflicting evidence that has to do with the effect of prenatal education. The prenatal education has to be based on physiology, not on everything that can go wrong in birth, but everything you need to do for birth to go to happen and to be a successful event, a happy and safe event. So we're talking about ways of gaining skills and working with the sensations, because the sensations are really important. Now, let's talk about the difference between pain and suffering. When I train healthcare providers all over the world, and I ask them, so we have epidural rates that are at 80, 90% in some countries, in some hospitals. And I ask them, what is your intention? What do you want by creating all of these initiatives on pain management? What is it you thrive for? And they say, well, we don't want women to suffer. And well, it just so happens no one wants women to suffer. But we first need to understand the difference between pain and suffering. So someone can experience pain, which is an unpleasant sensory and emotional experience that can actually be associated with damage, tissue damage, or no tissue damage. So pain is something more objective. Suffering is an incapacity to activate one's resources or to have insufficient resources to deal with the situation. So what this means is that someone can experience pain and not suffer because they feel that they have the resources to work with their pain. So they'll say, well, it's extremely intense, but I'm okay, I'm doing okay. And there are other situations where the signal is not intense, but there is suffering. There is suffering because we're not able to activate our resources, or we've done everything we could and we still can't manage what's going on. And that can create suffering. And that brings me to the case of the epidural. So I ask professionals, I say, well, you're giving epidurals to 90% of women to prevent suffering, but suffering is not related to how strong the signal is. It's related on how they're perceiving. So maybe with the epidural, we're not going to be reducing suffering, not automatically. So that brings me to the next slide, where we're going to talk about the components of pain. Now, this is something that a lot of people, that people just don't understand. So we know that we have at least 4 components of pain. The first component is called nociception, which means is the potential painful signal. So it's possibly an injury. Let's imagine there's an injury. So I drop a brick on my foot. So the foot will be signaling, will be sending message. So the nociception is the origin of the signal. So it's the lesion. And then I'm going to be experiencing the signal, and there's one signal that's going to go to the frontal cortex of my brain, and it's going to give me information about how strong the pain is. So it's a signal that has to do with the intensity of the pain. From my foot, again, there's another signal that's going to have a different pathway. So they're like 2 different highways. And this signal is going to go into my limbic system. So into the central part of my brain that's going to be associated to emotions and to memories. And so this is more subjective, and it's what we call pain unpleasantness. Now, these two highways are independent. So we could have something that's the highway of intensity that's very strong, and the highway of unpleasantness that's not strong, and could be the other way, and they could both be strong and both be not strong. But I just want you to understand that here there are objective and more subjective components. Intensity is more something objective. Subjectively is the unpleasantness, or how well I'm coping. And fourth, we have the behavior. So I might start crying, or I might become red, or I might be warm. And these are physical signals in my behavior that could be present. Now, this model, what it shows is that sometimes we have 1, 2, 3, and 4, and sometimes we have 2 and 3 and 4. And so that means that you can be experiencing pain, have unpleasantness, and have a behavior of pain and have no nociception. For example, if you're grieving the loss of someone you love, or if you just split up from your partner and you're experiencing grief, you don't have a lesion per se, but you'll be experiencing intense pain. You'll be experiencing it as being very unpleasant, and you'll probably be crying or yelling or whatever, a behavior. There are other situations where the variables, you could be experiencing having a lesion, experience intensity, unpleasantness, and you can't see. You look at the person and you can't see that they're experiencing pain. The reason why I'm showing this is that component number 3, the pain unpleasantness, this is what will tell us if there's suffering. Now, you could have a woman in labor, so she has nociception, so something that's creating an intense signal. Let's say the baby's in a posterior position and the baby is applying a lot of pressure on the sacrum or on the pelvis, and this will create low back pain. So she has nociception, and she's finding it intense, and she's finding it unpleasant, and she's finding it particularly unpleasant because she feels she's alone and she's abandoned and no one is taking care of her. And we give her an epidural. The epidural will reduce the pain intensity. It won't change that the baby is still applying pressure on the sacrum, so it's not changing the signaling, where the signaling is coming from, because the baby is still in a posterior position and still applying pressure. It's just that she's not feeling the intensity. But if she was experiencing a lot of unpleasantness related to the fact that she felt alone, that she felt abandoned, that she didn't feel, that she was scared, the epidural is going to reduce the intensity of the signal, but it's not going to reduce her emotions. Not necessarily. So this woman could still be experiencing suffering if her suffering is related to the fact that she's scared or that she's by herself. So this is really important that we understand this, because this is the root of what's going to help us understand how to reduce suffering in childbirth. So if we look at the next slide.
I love how you explained that, Julie, because so often I do hear that people feel the epidural is a one-stop cure, right? Mm-hmm. And how much is the epidural given? Because people are afraid, and those fears, as you said, can be alone and other things. That was really a beautiful descriptor. So now
we're going to go into the resources that women have that are hardwired in their bodies to help them work with the sensations of labor. So let's talk about the hormones. Now, we all know the work that Dr. Sarah Buckley has done on helping us understand, and Michel Audin also, helping us understand how these hormones will actually affect birth. So, of course, Deborah, you're familiar with the sex hormones and how powerful analgesics they are, right? Because this is part of a lot of what you're teaching.
Yes, so much so, right? And it's that old quote from wonderful midwife Ina May Gaskin, the energy that gets the baby in gets the baby out, and how similar the hormones and the physiology of birth is to making love, right? How our sex hormones kind of come in similar patterns, and they can either be supported and flow in the same ways that we feel safe and private and unobserved in our sexuality, or they can be disturbed in the same environment. I often say to people, how would you be able, and think of the place that you're giving birth, and caregivers, think of the environment that you're in. Would you yourself be able to have an intimate moment alone or with a partner? And if your answer is no, then you have to think, what can we do to help that environment and that situation so that we can all flow our hormones better?
So the hormones are actually what make labor easy and safe. And this is what ensures the survival of our species. So in the next slide, we see how these hormones are hardwired in our body. And what's important is not just that the mother and the baby survive. If you look at it 10,000, 50,000 years ago, or even 100 years ago, if women and babies survived, well, it was a very good start. But you wanted women to be able to breastfeed, because breastfeeding was the only resource that we had to feed our child. And if we weren't breastfeeding, the chances of survival of our child would be diminished from really a significant, in a significant proportion. That's why we had other women breastfeeding our children if we couldn't do it ourselves. So the hormones are there to support safety and health in mother and baby, but also breastfeeding and attachment, because the hormones are there to help us take care of our children. So if we don't have these hormones and we don't want to take care of our children and we abandon them at birth, their chance of survival are no, they're inexisting. So 100 years ago, 500 years ago, if we didn't keep our babies close to us and always answer their needs, we wouldn't be able to have them survive. So these hormones are really there to help protect our species. And if we look on the next slide, we'll have the different hormones. So Sarah has done a really good job of helping us understand how these hormones will protect childbirth and will protect the family. So oxytocin, of course, is the hormone of love, but it's also a very strong analgesic hormone. So it's a hormone that will act to relieve pain. The endorphins are what help transport us to another dimension. So we call them the hormones of transcendence, and they also have a very strong effect on pain relief. Then there are what we call the stress or the excitement hormones that are there to provide power in women. And then prolactin is what we call the mothering or the fathering, the hormone that will create attachment between the parents and the baby. And there are also the hormones that are involved in breastfeeding. So these hormones, and this is what I always have to explain to healthcare providers, is that the hormones, they circulate through our blood, and they will then have an effect on the fetus, on the unborn fetus. So whatever hormones the mother produces, the fetus will also be experiencing those hormones. That's why during pregnancy, we suggest to women to reduce the stress hormones, because these stress hormones are communicated to the fetus during pregnancy. And we have a wide range of studies that demonstrate that stress, chronic and important stress in women during pregnancy, will affect how the baby develops in the womb. So we know that the hormones that women release will impact the child. So that's why even during pregnancy and during childbirth, particularly during childbirth, we need to pay attention to create the proper environment that will help women optimize these hormones, because each hormone will play a role during the different phases of labor and delivery. And when we protect that environment and we create the environment where she's feeling safe, unobserved, protected, she'll be able to produce these hormones that will facilitate birth, that will reduce the sensations in birth. So that's the whole spiel around hormones. It's a summary, but fortunately we were able to put this into the guideline because a lot of healthcare providers behave as though these hormones didn't play an important role. And if we go to the next slide, we'll see that there are a lot of medical, well, I guess it's the slide after that. There are a lot of medical interventions that will have an impact on their hormones. So how about, Deborah, you talk about how we can optimize these hormones?
So a lot of the hormones we're talking about are hormones of calm, connection, intimacy. So simple things like movement. And we know from your study and from the Cochrane database, right? Just moving in labor is so helpful and provides comfort. But here you're seeing Piper and Chaz, and that kissing, touching, connection, eye contact, whispering words of love. I like to think that this is loving through labor. The more we stimulate oxytocin, our love hormone, and all the other hormones to flow. Many of us know that nipple stimulation can really work for that labor that's slowing down. How can we get that natural oxytocin going? But what's not talked about a lot is masturbation. And I certainly, in teaching around the world, have so many people tell me that they are masturbating in labor. And I feel like we all have been a little bit shy to really go deep into the sexuality of birth, but these hormones are part of our sexual life. So I do like to mention that we can offer all these ways for people to optimize their own mother-baby hormones.
Perfect. So now we'll look at, often people will talk about how women today are unable to work with their sensations or work with pain. There are two components to that. The first component is there are a lot of medical interventions that we are doing today. They're routine procedures that we have that increase the signal. So the first principle is do no harm. We're not doing too well with this in childbirth. There are a lot of interventions that will increase the signal. And how do we do that? So I just got back from France in a private clinic where they're automatically, when a woman arrives, they rupture her membranes. They give her synthetic oxytocin, and they give her an epidural. So rupturing the membranes will have an impact on increasing the signals because you're removing the padding, the natural padding that protects the cervix, and that will reduce the stimulation that you'll have on the cervix. So in given time, when the body is prepared, the natural impact will be less important, it will be less painful. So rupturing membranes, the use of synthetic oxytocin. Now, people don't understand that synthetic oxytocin is a hormone that's given through the blood. So we usually inject the mother in the arm. We give her synthetic oxytocin. It circulates in the blood. But this molecule doesn't cross what we call the blood-brain barrier. Let's see if I'm saying that right. Is that
yes?
Okay, the blood-brain barrier. So what this does is that it doesn't go into the brain. So this hormone, it doesn't pass into the brain, and it doesn't have the same psychological, emotional, feel-good sensation that you have with the natural hormone. So we mentioned that oxytocin and the other hormones, they circulate, they're released in the brain, and then they go into the body. So they have an impact on your emotions and on your feelings. But synthetic oxytocin doesn't cross the blood-brain barrier. And not crossing, it only has the physical effects. So it's going to create the contractions, but it won't have the psychological feel-good effects. And that increases the signal. So you see, we have two very important systems that are almost systematically, this happens in many healthcare facilities where they induce labor or they use synthetic hormones that will increase the signal. They rupture membranes. Many hospitals still stop women from drinking and eating. this can create pain and it can create suffering, because if you're in 20-25 hours in labor and you're not able to eat or to drink, even if you have an IV, it's not going to give you the energy of food or of drinks that are powerful. So hunger and thirst will increase the signal. Having an IV might reduce your mobility. Continuous fetal monitoring may be perceived as a threat. Your body sees lights, sees numbers, hears signals. All of this is signaling to your reptilian brain, I must be in trouble. I feel like I'm observed. So maybe it's the tiger effect, where you feel that something is dangerous and is happening to you. And this will increase the stress hormones, and this will increase the signal. So a stressful environment, being disturbed, being observed, all of this will modify the hormones and will also modify the signals. So you'll be experiencing more signals. Now we talk about the cesarean also, because especially with a planned cesarean, the hormones don't have time to reach their physiologic level. And so the woman is deprived of the hormones that usually increase in a significant manner during childbirth. And this makes for a more difficult adaptation in the postpartum period. So we said that during birth, the process of childbirth, women produce more oxytocin. They'll be producing lots of endorphins, the catecholamines, and prolactin. And if a woman has a planned cesarean and doesn't have the trial of labor, she'll be experiencing a deficit of these hormones, or a change in these hormones that can affect her resistance to pain in postpartum. They can affect the bond between the mother, the parents, and the child. It can also affect the ability of women to breastfeed. So we're having a higher levels of scientific research that are demonstrating these effects. We're also even seeing now, there are studies that are coming out that are demonstrating a positive correlation between synthetic oxytocin and depression in the mother in the postpartum period. So the more synthetic oxytocin the mother receives during childbirth, the more intense her depression, or the more severe her depression is in the postpartum period. So we're talking about huge effects. So this is the first part of the equation that explains why women are having so much trouble dealing with their sensations or with pain in childbirth today. The first part being, we're doing a lot of medical interventions that are increasing the signal. The second part of it is the conditioning, right? So we've been told, and we've bought into the truth that childbirth is painful. And Deborah, you're doing really good work in transforming that view, and in teaching that birth doesn't have to be painful. There are a lot of things that we can do to make it pleasurable.
Yes. Thank you. And that one of the questions I had, Julie, when you were talking about all this, and before you talked about how, the baby is also producing and being bathed in these hormones. And I know we're just kind of, I call it tip of the iceberg, on really looking at the effects of disturbing the baby's hormones. But I wonder, what we're finding out, because when we when we give an IV and dilute the mother's hormonal flow, when we give synthetic oxytocin and the mother's brain doesn't produce her own, that causes pain relief. I often think of mother baby, and Ray will appreciate this, we all love to dance. So when you can think about having that dance partner where you're in rhythm with, it's really like you're one for a period of time, right? You're flowing. And to me, that's the analogy of the mother-baby hormones in rhythm, in sync. And then I wonder that when we get an IV and we dilute the mother's flow, or we give the mother the synthetic oxytocin, are we creating a mother-baby rhythm that's off? Like, try to think for a moment of that dance partner you first get with, and you can't find the rhythm. We've all had those awkward moments with someone where we're kind of off beat. And are we creating an off beat between mother baby that's making labor more difficult, but potentially, as you're saying, Julie, rippling out? Is that something that we're getting more data, or that you're seeing?
Absolutely. And I'd even push that a little bit further in saying this. Think of this. When a woman has has an epidural, she's reducing her pain signals, all right? So she's still experiencing the nociception, but she's experiencing less intensity because the highway that sends the message of how intense the signal is under the effect of the analgesics. When a woman doesn't have the epidural, she produces, as a normal reaction to pain, she produces endorphins, which are an answer to pain. So the body is hardwired to produce endorphins to reduce part of the signal to help women cope with their sensations, all right? So if the woman has an epidural and she's no longer experiencing pain because she's not experiencing the intensity because she has an epidural and it's stopping the signaling, that means her endorphins will be reduced, right? Because she doesn't have pain anymore. But the fetus, the unborn baby, is going to benefit or not benefit from the hormones. So normally in a natural physiologic birth, the baby benefits from the endorphins that the mother produces in response to her sensations and to response to her pain. But because she's not experiencing pain, her level of endorphins lowers, which means that we're thinking that even these babies are not accompanied. So they don't have the hormone that reduces their own sensations, because the fetus has the ability also to experience, we believe, also has the ability to experience pain in childbirth. And so you see these hormones, all of the hormones, the oxytocin, prolactin, all of them, they play a role in the connection between the parents and the child, but they also play a role in protecting the fetus. So that's why I think that we need to get back to the basics of what Mother Nature intended, because the more we play around with that, thinking that we know better, the more effects we're creating that we haven't even all identified. So I concur with what you're saying. We're seeing more evidence. We need more research on this, but definitely I would say play it safe and just work on creating the proper environment so that the hormones can do their work. They're probably going to do them a lot better than what we've been trying to do.
Yeah, great point.
So let's talk about the second, I call these secrets, the hormones and the neurophysiology, because we don't take them into account, and a lot of healthcare providers and even parents don't know about these resources. So in the neurophysiology of pain, if we look to the next slide, we have 3 mechanisms. So these are scientifically proven mechanisms that we've been using for thousands of years. We just didn't know about how it worked in the nervous system. Now we do know that. But these mechanisms are really important in the sense that they help women work with the sensations that they have. They help men also, because these mechanisms are hardwired in both women and men. So if we look at these 3 mechanisms, they act in different ways. And I think it's important that people understand the ways in which these mechanisms work so that they can activate them through the different techniques. So we'll start by explaining the mechanism, and then Deborah is going to describe the techniques that are associated to these mechanisms. And we'll also see the scientific evidence that we have that supports these, the efficiency of these mechanisms. So the first is the gate control theory. So what the gate control theory, this has been developed and understood in the 60s by Melzack and Walls, so scientists from Canada and from the UK, that have demonstrated when you create a light stimulation of the painful area, you're going to be blocking part of the message. And the message, the highway that you're going to be mostly affecting is the intensity of the pain, so how strong the signal is. So in the next slide, we'll see how this mechanism actually works. So the red signal that we're seeing is the signal of pain, and it's signaling on a nerve fiber, so on a nervous fiber. And when we caress the same area, so if we create light massage or light touch on the same area, we'll be activating the blue bubbles. And inside the spine, there's an inhibitor interneuron that's going to act and connect between the non-painful the blue fiber, and the red fiber, which is the painful fiber. And the message that's going to be perceived in the brain is going to be diluted. So imagine pain is the boiling water. Okay, you have a sink with two faucets. You open the faucet, the hot water faucet. This is, let's say, the painful signal. It's very hot. When you caress the painful area, you're going to be opening the cold water. And you're going to be mixing together the hot and the cold water. So the non-painful and the painful signal, you mix them together. And what's perceived is lukewarm water that's not as painful as the boiling hot water. So this is the gate control mechanism. So it works only if you apply the light massage to the painful area. And it works mostly by affecting how intense the signal. So it's going to reduce the intensity of the signal. And it works while you're stimulating. So if you hit yourself and you massage, it's going to help reduce the signal. If you stop massaging, the signal will come back.
Fantastic. I love that image, Julie. Great way of describing it. So this is one I have to give a shout out to Rachel Kemble for this photograph. I just love that connection. You can kind of see the hormones kind of bubbling up in both of them as they love through labor. But as you said, Julie, the touch, the massage, hot and cold compresses. And I think sometimes we forget about how easy it is. And even within an environment, people say, well, what if there isn't a microwave? There's always a sink. And I love to go and just take a towel and put it under nice warm water, or the little water bottles for those that are in parts of the world with access to a hot water bottle. This can be wonderful just within the room to fill up. And other people actually make hot socks where they take a cotton sock and fill it with rice, and if there is an opportunity for a microwave. The same with cold, just, taking some cool water and putting it on can help, or many hospitals or facilities have those cold packs that you can smack and then wrap them around. Moving and changing position. And I often like to look back what I call historically, where there was more celebration, sometimes in birth, and dancing. There have been some great viral videos going around right now of doctors and nurses and midwives actually choreographing dance routines for their patients. And I laugh because I thought, what a beautiful way of bringing celebration and movement. And we saw the image before of Piper and how much that water immersion. Think about when, Julie, you were talking about touch, I think of water just touching us all over, right? It's giving us, whether it's a shower, but here we're talking about immersion, but our whole body is getting stimulated and relaxed by the water on it. And then I always have to smile when we add vibration. And a lot of people are bringing massagers or even their own kind of touching a spot, and we can make our own vibration with just kind of a jiggle or a wiggle or a movement. But other people might join me in thinking other ways that we go to vibration as well. And we're seeing more people move that pain to pleasure in using these aspects of the gate control theory.
Absolutely. And when you were talking about sexuality in childbirth, using a vibrator on the perineum or even inside the vagina, the vibration is going to create a non-painful stimulation on the painful area, which will block the message. So for us, it's a bit of a jump, but I think that if we get familiar with this, if we create the intimacy that parents need to give birth, just even having the vibrator on the desk is a message, right? Saying, well, this is a private event. This is not a public showing. So beware, I might be using this during my labor. So it kind of creates a bit of a sacredness around the event. But the neurophysiology of using the vibrator, not only does it produce the good hormones, but it will also block the signal wherever you're going to be applying the vibrator.
Yes, and lots of pleasure. And I'm glad you're saying that, because I feel that we all have to address if you're listening to this and having a reaction of like, I can't go there, to really address why, because I think that we have to honor, in looking at the physiology, looking at the hormones, we all need to address what has been the block that we've disconnected the sexuality, the sacredness, and all the tools that can make birth easier. And so as caregivers and as birthing and birth givers, we have to look at where can we honor and make space for everyone to move in their own way and hold these options.
And Deborah, I love this photo, or the last one with the partners together, because it's such a good demonstration too. I love the phrase that you use, love through labor, and just his hands gently on her breast are releasing that wonderful oxytocin hormone too. So that photo has just done a really good job of demonstrating that wonderful love through labor. Thank you for sharing it.
Oh, you're welcome. Thank you. And thank Deb and her husband for sharing that with us. Now, water immersion, we just talked about it, but I think another beautiful image, I mean, look at the connection. You know, water allows us to really sink in. When I look at this, right, I see the connection between woman and partner, their hands are touching, the water is part of the gate control. So as Michelle O'Dant says, you know, we often get in the water in labor and get that ah response. It just allows us to, rather than feel pain, to transform it into other sensations. And as we know from years ago, right, Brantley Dick Reed, the more we relax, the more labor can proceed, and we're not stimulating that fear, tension, pain cycle. So I love this image. And here is me as a doula at a birth, and you can see partner giving that light massage, just like Julie said, that gentle touch. And I'm adding to it by even taking a container of water and letting the water run down her back. So she's getting the benefit of immersion in water, which is triggering gate control, but also these extra techniques. And Julie, you had mentioned how important it is, that layering, right? To have support, which she has here, both of a doula and her partner, but then adding the extra techniques as well. And here's moving ambulation, that leaning forward, finding positions. I often teach people kind of that moving, like Penny Simpkins' 3 R's. I love Penny's 3 R's of relaxation, rhythm, and ritual, but getting that movement, kind of like putting on tight jeans. I always love to say, if you were laying down and I gave you tight jeans by your ankle and told you you had to stay laying on a bed and try to slide them on, most of us would never get them on. But if you've ever put on really tight jeans, you know how much you wiggled and jiggled into them and jumped and hopped and pulled and tugged. And when you think of that baby moving through our body, those kind of wiggles and motions and finding where it feels right, is right. So another beautiful image, again, using touch, position, support, and a circle of support. We're seeing that hand in the front as well as in the back.
And Deborah, on that, back to that photo, that mom was also a good demonstration of the 3 R's, the ritual part, because her ritual was have the contraction leaning forward on the beanbag and everybody had their position. Before that, she was standing up and walking around. However, the next moment she had to get into her position again. So that was her strategy for working with her labor, and a VBAC at that.
Ah, beautiful. Thanks, Ray.
Yes.
So in this slide, we're talking about the research results that we have about the gate control theory. So my colleagues and I, we published in a scientific journal a couple of years ago, a meta-analysis. So it's an analysis of many studies, 57 randomized controlled trials with 34,000 women, where we separated the techniques into mechanisms because we wanted to see the effect. And because in non-pharmacological methods, we don't have as much evidence as with pharmacology, right? Because of the lack of financing. by pulling together all of the studies that had to do with the gate control theory, we were able to have more subjects participate in the study. And so what we demonstrated is that if someone was only to do gate control, so let's just imagine that they're not supported, but they're going to apply light massage, or they're going to bathe by themselves, and they're going to caress their zones, we would be reducing the rates of epidurals of about 20%. We'd reduce the use of synthetic oxytocin, but you'd have no difference in maternal satisfaction or fetal morbidity. So it's a good mechanism. It works in reducing the epidural rate by about 20%, and it reduces synthetic oxytocin. But it might not be one of the best mechanisms. So this, remember that the gate control theory acts and has an effect mostly on the intensity of the signal. Let's remember that. So if we go into the next mechanism, this is called a diffuse noxious inhibitory control mechanism. It's quite counterintuitive, because what we're saying is you need to create a painful stimulation anywhere on the body at the same time as someone is experiencing pain. So what we're saying basically is that if a woman has a wave or an urge, a surge or a contraction, and she's experiencing a painful signal, you would create a second painful signal. So you would create this second painful signal to produce the release of endorphins, so natural endorphins, the neurotransmitter. So it's not the same substance that's circulating in the blood, and that is a hormone, because the neurophysiologic mechanisms we're talking about are neurotransmitters. So they're going to inhibit the signaling of the nervous fibers. So they act in an independent and a separate system than the hormones. So when you create a second pain during a first pain, you'll be releasing endorphins, and these will affect the intensity of the signal. So if we look at the different techniques that you can use to activate the Denick system, it could be any type of pain that you create. So you could just be women in Algeria, they'll be holding a rock, a small rock in their hand, and when they have a contraction, they hold the rock very tightly, they create pain in their hand, which is second pain, and this will reduce or inhibit the first pain. It can also be done through acupuncture or the TENS unit, which is an electrical stimulation that is sent between two electrodes, and this is placed anywhere on the body. And this would also create, you could use the TENS unit with high intensity and low frequency, so strong signals that would create a second pain. Can be also used, activated through the use of sterile water injection that I'll be showing in a minute, and the use of ice. So basically, this mechanism is very easy to activate. It can be activated by a partner, or the woman can activate her own second pain, and it can be activated anywhere in the body. So she doesn't have to create pain in the painful area. She'll be just creating pain anywhere in her body. If we look at the neurophysiology of it, so there's the first signal that goes to the brain, and the brain will interpret that. If you create a second signal, this signal comes to the brain, and the brain doesn't understand what the nature of the second signaling is. What does this pain mean? Is the second pain more important? Is it dangerous? So the body knows about the first pain, maintains the first pain there, because the body wants you to respond to the pain. So if I drop the brick on my foot and I'm experiencing pain, the pain is going to tell me, don't walk on your foot, get your foot checked, put some ice on it. So the pain is going to be telling me what to do. Now, if I create a second pain somewhere else, the second pain is temporarily going to be producing endorphins, a substance that will circulate throughout the nervous system, that will block the signaling of the fibers, the nociceptive fibers, all over in the body, including the first pain, so that the brain can analyze the nature of the second pain. So why and where and how is the second pain happening, and is it dangerous? So what we're going to be doing in childbirth is that we're going to bypass the system. We're playing a game on the brain, and we're telling the brain, oh, the woman has the first contraction. It's true. The brain wants you to take care of the contraction. So if you actually even identify, why do women have sensations in birth? Why does that exist? Well, the sensations are useful in birth, because what a woman is feeling is, first of all, telling the woman, go find your tribe. Okay, 10,000 years ago, if you were to give birth without experiencing any sensations, you could have been giving birth while you're away picking berries and you're by yourself in the forest. And that wouldn't be very safe, would it? Because you could have your baby attacked, you'd be very vulnerable. So the message is signaling the woman, find your tribe, find the people that you need who will protect you, because you're going to be vulnerable while you're giving birth. You can't run, you can't flee, you're gonna be in a situation where you need some help. So you have sensations, go and seek help. But when, and the sensations will also be telling you how to move and how far you are in labor. So they're gonna give you an indication of what's going on. So the body doesn't want to reduce that. The brain wants you to work with your sensations. But when you create a second pain, the brain is going to say, well, why does she have this second pain? Is it dangerous? Has she been bitten by a beast, or is she, what is happening? So the brain will temporarily produce endorphins that will circulate all over the body, except on the second pain. So the women can actually pay attention to the second pain and say, well, do I need to do something about this? So if we look on the next slide, there are many different ways that we can create the second pain. I use acupuncture points because in Chinese medicine, we've discovered that the acupuncture points are related to energy systems that we have in our body that we call meridians, and that when you stimulate certain points in the body, you'll be facilitating labor. So there are some points that will help dilate the cervix, some points that will increase the contractions or the efficiency of the contractions, some points that will help the baby descend into the pelvis. So what I've done is I've put together many different points that we have that are usually used in the clinical setting with Chinese medicine. And what we teach the partner is how to create a second pain in these acupuncture points during a contraction. So creating a second pain would have two effects. It would have the effect of reducing pain by the release of the neurotransmitter that's called the endorphins. And it could possibly also have the effect of Chinese medicine, which would be to facilitate labor.
Fantastic. I love using, and just to clarify, you say they are acupuncture points, but we'd be using them with acupressure when we teach partners and others to do it.
Exactly. So if we look into the next slide, we're going to see here the use of sterile water injection. This is a super technique that should be compulsory before any epidural. This is the injection of sterile water. So it's just water that's injected in the intradermal space. So it's on the top of the skin. And when we inject this water in small quantities, what we're doing is we're creating counter irritation. So we're creating a pain. So you see that the needle is inserted really on the top part of the skin layers. And when the water is injected, it's going to separate different layers of the skin, and by creating this this bubble that you can see on the skin, and that creates a painful signal, and that will block all of the other signals in the body because of the intense sensation that's felt there, and that only lasts about 20-30 seconds. the scientific evidence that we have behind these sterile water injections is very good. So we have pain relief of almost 2 hours just by injecting water. So this should be definitely one of the steps, not the first step to use, because support, love, working with the hormones and all the other techniques that we've identified are extremely efficient. But if that's not enough and we need to go further, we should go to the sterile water injections before using the epidural.
Julie, the sensation apparently is intense stinging.
Yes, it is.
Yeah.
Yeah. And it lasts only about 20-30 seconds, but it's like being stung by a bee. It's pretty intense when it happens. But it's going to happen during a contraction, so it's going to reduce the pain or the sensation of the contraction, which would be very good. So if we were to use the diffuse noxious inhibitory control, creating a second pain, we'd be reducing the epidurals of about 40%. So it's more efficient than the gate control. We'd increase maternal satisfaction and feeling of control, but we'd have no effects on medical interventions. So this will act mostly on the reduction of the intensity, the signal, you know, the highway that signals intensity. Now, if we look to the last mechanism, which is the control of the mind, or what we call attention deviation, this is where we're going to be getting very important effects. So how does this work? Is that the conditioning that we've had since our birth, the thoughts that we believe, our beliefs, our memory, they create emotions and they create effects in our bodies. So if I think that I'm going to have an exam at the end of this presentation, it's probably going to create the emotion of stress. And this stress could have an effect on my body. I might feel some cramping, or I might feel pain in my neck or in my back. So what we're saying is the cognition that you have, what's inside your head, the way you perceive birth, the way you perceive, different events related to birth will have an impact on your body. And this will, the conditioning that you will have will create an effect on the unpleasantness of pain, so on the emotional aspect of pain. So if we move forward on the next slide, so attention deviation has to do with everything that's going to control your mental, your emotional state. And that's where continuous support comes in, and all of the techniques that have to do with changing your mind setting. So it can be anything that either changes your mind, so you learn that a contraction is not a contraction, it's a wave, and it's there to help your baby come down. So instead of saying a contraction is bad, a contraction is good, is going to help my labor. When you meditate, when you relax, when you're mindful, when you focus your attention on something different, when you feel the love, you feel the support, when you have people who support your plan, they support your desires. So all of this will have an effect on your emotional state. And that's really important. And this is where we're going to see the most important effects. So if we look into the next slides, we see that when the partner is being kind and is talking to the woman and saying, "You're good, you're great, we're working, we're together," that's going to help deviate the attention. The next one, continuous support by a doula, by partner. All of this has an effect on the emotions, right? On the unpleasantness aspect of pain. And then having positive affirmations. I know I can do this. I'm working with my baby's benefiting from my hormones, all of the thoughts that we're having in our mind. And this is where we get the results. So the results of these mechanisms were phenomenal. We were just impressed with when women feel safe. So what this means is when women feel safe, they have better births. And we have, from our meta-analysis with 34,000 women, we demonstrated that the mental, emotional, and psychological state in which a woman is the best predictor of how birth is going to go. So when a woman is zen, is calm, and feels protected, she'll have a better birth. So we have a 60% rate, a reduction in cesareans. This is phenomenal. We're going to reduce instrumental delivery, the use of synthetic oxytocin. We're going to reduce bleeding, negative experiences, and we're going to increase exclusive breastfeeding. And when we look at the result about the epidural, so this, if you only use this mechanism, you're going to reduce the rate of epidural by 10%. Now, that's strange, don't you find that the DNIC, the creating a second pain, would reduce the epidural rate by 40% and the gate control by 20%. And yet, having continuous support, making a woman feel safe, is only going to reduce the epidural rate of 10%. And the reason for this is that the control of the minor, the attention deviation, acts on the unpleasantness signal. The unpleasantness signal is the emotional signal of pain. So what this says is that if we really want to reduce medical interventions like cesareans and make births healthier and happier and safer, we really need to address the emotional part. So the support part is really what drove all of these results, because we had a lot of studies that had to do with support. Making a woman feel safe is fundamental. Combine that with the gate control plus the DNIC, so creating the second pain, we're going to even have better results. So that's why we came to the conclusion in the guideline is that we always need to have support. Support plus at least one other mechanism. So the creating a second painful stimulation or massaging the painful area. And that's where we'll get the best results.
And this is fantastic to hear, Julie, in the way you're presenting it too, because the latest Cochrane review on continuous support actually states that why there is a benefit to another companion that offers continuous support, it is the companion, usually called the doula, who's undergone some training that's making the biggest difference. And what that would say to me as a doula trainer, and Ray too, is that we are teaching these additional comfort techniques or the different measures you're talking about. So doulas, just as part of their role, are combining all three.
Exactly. And I think that what's really important, that I used to be a family mediator negotiating divorces. It's very important to involve the partner, because we even have the science between the hormones. We know that when the partner is involved and feels useful, he's going to be producing prolactin, which is the hormone of attachment and of feeling involved with the baby. And that's really fundamental in preserving couples and preventing divorces in couples, is that the partner feel that he's part of this unit. So that's why if doulas are there or midwives or nurses, they need to teach these techniques to the partner if the partner is present, so that the women can benefit from the support, but also the partner can benefit from the strengthening of the bond between the mother and the father.
Yes, well said.
So the conclusion to this is that non-pharmacological approaches to pain management during childbirth, they offer many benefits for the mother and the child. And they reduce the use of obstetrical interventions, and this makes for happier and healthier births. So step number 4 is really fundamental. It's part of all the spectrum of women's rights and what we need to have safe and happy births. And I think that we have, with the guideline, the Canadian guideline, that we hope will be an international guideline with FIGO soon, that we have the knowledge, the scientific evidence to support the use of this. So for any facilities that only have pharma, this is wrong. We need to have both resources, both non-pharmacological and pharmacological, and start with non-pharma first because it's the safest.
Thank you so much, Julie. This was really fantastic and eye-opening. I just love how you've put the data together in such a beautiful way and integrated all the different ways we can find comfort, honoring the hormonal physiology, and really using that first. And I know that many people here are going to want to find you. So right now you can see Julie's email and your website. And hopefully as this guideline is out and available from the SOGC, Julie, right, you'll be able to put something so people could be on your website, bonapace.com, where we could see where we might be able to find or buy the guideline.
Absolutely. So thank you for your great work, all of you, and let's keep on making birth better, happier, and safer.
Thank you. And thank you so much, Ray, for helping us to put all this together. And I hope all of you will go to our YouTube channel and our website, imbci.org, to watch this, share this with your friends and colleagues so that they also can learn the benefits. And please enjoy our other 9-step webinars and presentations, and join us for our upcoming webinar series to go deeper and learn more. So thank you. And everyone that's joined us virtually, please, we welcome you on Facebook to send us comments on the International Mother Baby Childbirth Organization Facebook page and or through our website and email. So thank you again, Julie and Ray, and thank you to all who have joined us.
Thank you, Deborah. Thank you, Julie.
You're welcome.